Hey, Luke. This is Harold Pollack at healthinsurance.org doing a curbside consult with Luke Shaefer, and this is actually sort of a little interlude in the interview that we did. We were talking about your book. If you want to hold up your book,
With pleasure.
$2 a Day, which is just a rocking bestseller by academic standards at the moment. Really had a big
Thanks.
impact, you and we were talking how you've been doing briefings in Washington, D.C. at the Center on Budget and Policy Priorities and with Senate folks, and have some great excerpts planned, which I won't spoil, but a lot of media outlets that are showing interest in the book. And what, why do you think, by the way, it's attracted such interest?
I think that's a good question. I mean, I've been interested to see what people picked up on, and I think of all the articles that have gotten play, perhaps the one that has come back to me more is the most was an excerpt in the Atlantic that really focused on Jessica Compton, one of the moms who tries to donate plasma twice a week. It's the only source of income that her family has, and that seemed to have a very very much a visceral impact on people, I think. So what we really tried to do was tell a big picture story about what's going on in the low wage labor market and what's going on with our government programs for the poor. And a big piece of that is Medicaid, so I'm excited to talk about that. But to do it through stories and to do it through people's lives, and I think to some degree we were successful in sort of capturing people's attention and bringing some of it home. So I'm really happy about that.
Now, let's talk about Medicaid, because Medicaid is the main tool in some ways that we've used to certainly to provide health care to poor people. And I should say that you and I actually, our first work together was on Medicaid and on the impact of Medicaid and CHIP for kids. And maybe we should start by just reviewing, since you're the first author, there. We should at least mention that I'm sure that everyone that's listening to this is a regular subscriber to Health Services Research and some of the other
Read
journals
this
that we
particular
publish in.
article, I'm sure. Yeah.
Yeah, but why is CHIP so important and Medicaid so important for low-income kids?
Um, well, we note this in our book, and it was really the genesis of this paper. Of one of the great things we did in the 1990s was pass SCHIP in 1997. So sort of on the heels of the 96 welfare reform, and I think going along with this trend towards trying to provide supports to low income working families. So we did this expansion of SCHIP. It allowed states some flexibility in just providing coverage to poor and low income kids up the income distribution, and states really responded. And I think all states have SCHIP eligibility thresholds that reach 200% or twice the poverty rate, right? Some go up to 300, I think maybe even a little bit more than that. And it really caused a shock downwards in the number of uninsured kids. And there was a lot of concern at the time about crowd out. How much were these kids that would have had private insurance that were just shifting over to public insurance? And you and I, as I recall, wanted to try to further develop the conversation about what the impacts of SCHIP were. And we were thinking in particular, public health insurance tends to be more comprehensive and cost families less, less in premiums, less in copays. And so you might see this big financial effect of reducing what people were paying themselves. And there were some, I think, methodological challenges of selection into the program. And we particularly saw that kids who were in worse health tended to move from private to public, and we dealt with that in using some instrumental variables that were well documented in the literature, and we found this quite significant impact on reducing medical costs for families of a switch from private to public. And I think since then that's been substantiated in some experimental results that we had out of Oregon, of course.
Now, we'll get to Oregon in a minute, but I think just to build on what you said for a moment, both the good and bad about what we found. Good in terms of sick kids in particular really benefited from going on to CHIP, and there was definitely more of a movement of kids who had health issues into the program, than there was among other kids. And at one point we calculated it's worth something like $1,500 for a family that was provided. When you think about the $2 a day standard in your book, that's a substantial amount. Now, one of the challenges that really bring out the importance of the Medicaid expansion is implicit in that paper, which is as we expanded CHIP, there are more and more families where adults would go without insurance, and they'd be like, okay, I can get my kid on CHIP. I can't really afford insurance for myself, and there was a lot of that in our data, and there's actually a lot of that in your book. A lot of the kids that you talk about, they're pretty well insured, as you describe it, but not at all true for the adults.
Yep, that's absolutely what we found. In fact, I might say that Medicaid did the best of blanket covering people for kids, and then for the adults, we would see a lot that weren't covered. And we had a few experiences, which I think are not that uncommon, where often when a state hits a budget crunch, it's adult Medicaid services that are the first to go. So like adult dental coverage in Medicaid, we saw examples where we had Jennifer Hernandez in Chicago, and has a long work history, super hard worker. Her gums were just in awful condition, and I found it a little hard to look at her, I'm embarrassed to say. I actually had a trained social worker call around the city of Chicago just trying to find a free dental clinic that would give her free care. She has no money, and we couldn't find a place. That's not to say it doesn't exist, but a trained social worker couldn't find it. And when we looked into it, the adult Medicaid dental insurance had just been cut like a month before we met her. And I think that's indicative, so you have on coverage, not on coverage for the adults, as well as sort of changes in what that means, at least around the edges.
Now, how do people in states that just didn't expand Medicaid? I mean, you went down to the Mississippi Delta, and actually, I guess in your Tennessee work, Medicaid did not expand. Was it palpable that there was a real difference there for families because there was no Medicaid expansion, or is it something it's a little early to see? What did you see as far as the Medicaid issue goes?
Well, I think we saw it. So, like one interesting story was Paul Heckewelder and his wife in Cleveland. They were in one of these situations where all of their kids were grown. They had like 20 people living in their 2-bedroom house, but she was terribly sick and had no health insurance. So I think she was maybe 59, 60. So she was in this sort of gap because all her kids were grown. She wasn't eligible, and she had a stack of medical bills that was, I think we took a picture of it. It was like this high, and that should be solved in Ohio. I mean, at least, there's something we can get her on now with the expansion, right? And we saw that in Chicago too. I think adults were more likely, we were mostly with adults with kids, but I think everyone we talked to in Appalachia, the parents were not covered. And in the Mississippi Delta, I think, we didn't exactly look at this, but, another problem in the Mississippi Delta was just plain access. There's a county, it's one of the counties in the area we were in, there's no ambulance service. We were told by multiple people, so people can't even get to the hospital.
One of the points that raises is there's sort of two ways that the Medicaid expansion helps. It helps the individual secure access, but it also
Mm-hmm.
provides the financial foundation for the whole ecosystem of care. And so
Mm-hmm.
one of the things that so many of the severely poor people that you're interviewing, even if they're in a state that has a Medicaid expansion, if they're undocumented or if they have life issues, they may be turning to things like the emergency department. And
Mm-hmm.
one of the things that has been really strong since health reform is that uncompensated care costs have just plummeted in the expansion states, and they haven't budged in the non-expansion states at all. And if you look at all the major private for-profit hospitals in their financial
Mm-hmm.
reports, they've all emphasized this. And in fact, their stock all spikes whenever there was both Supreme Court decisions that were favorable to the Affordable Care Act. Their stock spiked, uh, the moment that there was favorable news, because and so if you want to pay for an ambulance, even if an individual is uninsured for that ride, if there's sort of seven other people that you can get paid for,
Right.
then you can actually have an ambulance. And
I mean,
if
it's almost like insurance. It's an insurance pool for the providers, and I mean, it just it reduces the risk. I guess I'm not sure how to say that, but
And there's also economies of scale that make it easy for, if there's big fixed costs, Medicaid can help pay for those, and then it's a lot easier to help that extra patient who's got an issue that's hard to get paid for. And you go down to the Mississippi Delta, and there's just no oxygen for that medical
yeah,
ecosystem.
yeah,
It's a really tough situation. And it's a really tough situation for the local economy too, because probably some of the people you interviewed could have driven that ambulance, or could have
right,
done something.
yeah, yeah, exactly. Have we seen? So we've seen reductions in uncompensated care. Have we seen any changes in the cost curve, Harold? Do we think it's going to result in lowering costs overall, or is it still sort of remain to be seen?
I think it remains to be seen. The remarkable thing is that it certainly has not increased costs. And I mean, Medicaid is so cheap compared to other forms of insurance. And the irony is, all of the political debate is about people who are really not that expensive to take care of. And
Right.
on average, I mean, some of the people that you interview have really serious health problems and have to be dealt with. A lot of those people, they have pretty basic needs, and they're not that expensive. So what's happened in terms of the cost curve is the overall cost curve has been bent down in a
Yeah.
favorable
Yeah.
direction, and there are parts of ACA that have helped with that. I think
Yeah.
it's mostly helped in Medicare and some other parts of the system, but the Medicaid expansion has been, quite economical, and I think it's been, I think it, there's been some services that there's more intense needs for, and some of it comes up in your book. A lot of people using mental and behavioral health services.
Yep.
There's just a lot of mental health need among some of the new enrollees, so we have to deal with that. We haven't figured out how to get some of the some of the systems like substance abuse treatment that have kind of existed off on their own in a silo. uh, they have to figure out how to work with Medicaid, and some of that's very nitty gritty stuff, like
Yep.
does our computer system bill Medicaid and all that kind of stuff.
Yeah.
So the jury is still out about the blocking and tackling of it. But one thing that we do know is that the cost of it has, the forecasts for costs going out are actually lower than they were predicted to be in
Yep.
2010 for Medicaid, even taking into account that not every state's expanded and all that kind of stuff. Now, you also mentioned the Oregon experiment, which speaks to how Medicaid helps, but maybe doesn't help enough in people's lives. I wonder if you wanted to pick up on that.
Well, yeah. So the Oregon Medicaid experiment was sort of a randomized trial of adults who were not eligible in Oregon off a very long waiting list, and my interpretation, and you're more expert than this, is we randomized and we followed health outcomes for a couple of years, and financial outcomes, and mental health outcomes, and the the physical health outcomes, I think, were maybe a disappointment to people, that there wasn't a lot of impact and things that, some of our best people thought we should be able to impact. The financial outcomes, I think, were pretty good, right? That we actually saw reduced out-of-pocket expenditures, maybe at levels that were, in the similar scale of what we found in our paper. And actually, there was some really positive mental health results, right? That we reduced sort of anxiety and depression, and as I've been meeting with families, I think, in terms of the physical health, there's just this. It seems to me like there's this compounding effect for people at the very bottom, that you're talking about repeated exposure to stress and trauma. And I don't know if I mentioned in our last segment that I got into the literature on toxic stress, and it was just really quite striking as I would read the papers and then go out into the field, and I feel like I could see the manifestations of toxic stress exactly as they sort of had been and written about in the paper. And I think it just takes a long time to, I think, impact health outcomes when you're dealing with that situation. And frankly, I think it's probably too much to ask the healthcare system to do on its own. The problems that are really impacting the health, and I know you've written on this, are really outside of the domain, of if you've got these unstable living arrangements, unstable jobs, it's very hard to keep continuity of care, right, among physicians. And, if you're just constantly dealing with the stress of where's the money going to come to keep on going for another day, I'm just not sure we can sort of expect providing health insurance to solve sort of all the health problems that people face.
I think that's right, although I tend to think the Oregon one, that it was more helpful than a lot of people have taken from it in a couple ways. One is some of the basic issues people worry about in Medicaid turned out to be much less of an issue. There's this stereotype that if you have Medicaid, you can't get in to see a doctor, and that is basically like a fake insurance card. And people were very happy with the coverage that they got. They had people get into all the data we have are when people get onto Medicaid, they get appointments. They're just as happy with their coverage as basically they would be under the kind of private insurance they're likely to get. If they say, are they as happy with Medicaid as they might be with the insurance that Harold Pollack gets that costs $20,000 a year for my family? Probably not. There's a difference there, but that's not what they're going to be getting. And also some of the expectations. The Oregon experiment was pretty short, and there weren't that many people with serious health problems. So we really have no idea I think we learned from that experiment, if you're expecting a really quick benefit on something like high blood pressure, you're probably not going to see it right away.
It's going to take a while. And was it a pretty low take-up, Harold, in terms of the take-up group?
Yeah, it was pretty low take-up for a variety of reasons, just having to do with the mechanics of running an experiment. And it was a beautifully done experiment that took all that stuff into account. But what that led to was it meant that you would have had to have seen a pretty dramatic effect in a pretty small number of people in order for the experiment to actually see that there was benefit. So if we, for example, looked at people with diabetes where we were lowering their blood sugar level, they just didn't have the ability to see that. Although I think that I was disappointed that we didn't see more benefit for some things like blood pressure and also things like smoking. I think this is where it gets into the sort of whole psychosocial dimension. All your folks were a lot of your folks were smoking, and we don't see any real benefits from improving people's health behaviors. And I think that's that's one area where health insurance just seems to be less powerful than we'd like it to be. So if you look at things like obesity, diet, smoking, you really don't see any concrete evidence that we're getting people to live healthier lives, although we do see that we're managing people's health conditions better. And so it's both so it's a half full, half empty thing.
Yeah.
People
Yeah.
don't have to worry about losing their house because they're going to get sick, which is fantastic. Uh,
That's a good outcome.
yeah, and in your case, people be less likely to be homeless or to be chased around by bill collectors.
Yeah.
Uh, but we got some work to do on the health side. There,
Yeah.
I know you're a
You were probably watching the new health insurance numbers that came out a couple of days ago, and I found it striking that sharp reduction in the number of uninsured. I think we went from 13 something percent to 10.1%. I mean, that's a success.
yeah, out is kind of amazing, especially since it's been a rocky road and it's a big challenge. But I
Right.
think you could argue that the past 5 years have been the best 5 years in the history of health policy. If you look at costs have really come under
Yep.
control to a much greater degree. The quality of healthcare has gone up a lot. Uh, More people are insured, and there's been continued progress that I don't think people fully appreciate. Death rates have really been dropping consistently over like the past 20 years, and it's been continuing. If you look at age-adjusted death rates in America,
Hmm.
it's just remarkable. We just continue to, uh, uh, largely because cardiovascular diseases we're doing a better job on, and smoking is down. Americans are really living longer, and and the health system is genuinely getting better. Now, it shouldn't cost $3 trillion to get the kind of outcomes we're seeing,
Right. Right.
uh,
Right.
but uh, but I'm thinking, if we can have another 5 years that looks like the last 5 years in terms of progress,
Right.
especially if we can get a couple of the states like Texas and Florida uh, and Mississippi to come into the Medicaid expansion, we're going to have a healthier country. And it's a little hard to see that now because there's sort of we're sitting here debating Donald Trump level of policy discourse,
Right.
but
Where we're
uh,
at.
but it's there, and I hope that I think your book actually is going to contribute to this because it highlights the problems that we're not dealing with well at the very bottom,
Yeah.
that where we really do have a lot of public health problems we could deal with. And so congratulations on its success, but I'm rooting for your book's success, partly because I'm rooting for you, but partly because I just think that it's highlighting these issues that we need to get to, and that we have the capacity now, with the Medicaid expansion and
Yeah.
other tools to really go after in a better way. So,
Thanks, Errol.
so maybe
Yeah.
this is a good place uh, you know, to stop this portion of the interview. But I'm very gratified that you're getting the kind of attention that you're getting, because I think there are a lot of those people living on $2 a day could use a little exposure, and your book does that beautifully. So congratulations on that.
I appreciate that. And in this interview, I feel like I learned more from you than you possibly learned from me. So it's always good to talk to you.
Well, thank you. Well, you paid me tuition, so it seems like that should be it should go that way. Great to talk to you.
That's good. All right. Take care.